Hello guys, good morning. I welcome you all on Unacademy, India's largest learning platform. Myself, Dr. Nidhi, I'm your physiology educator at Unacademy. This is my Unacademy page, that is unacademy.com/KGMC. You can follow me out there so that you will get notification of any special classes or plus classes, upcoming classes. So this is the code Dr. Nidhi. If anybody wants to join any paid course, you can use this referral code to get additional 10% off. I have taken many plus classes, many special classes, so anytime you can join and revise your topic. So this is the let's embark your NEET PG 2023 because we are going to have this amazing offer that is when you take subscription of 1 year you will get a 6 month extension free of cost. So do enroll yourself right now by using the code that is Dr. Nidhi. So moving further, the price hike is going to be very soon by 20%, so you can save your money by enrolling yourself right now. So we are having two type of subscription: plus subscription, iconic subscription, and an Academy Lite subscription. First, coming to this plus subscription, what all are the benefit? You will be able to access both the live and recorded session. By chance you miss any session, you can see the recorded version. You have an opportunity to learn from India's top educator for the medical examination. We always conduct this in live tests and live quizzes. From that you can analyze your preparation at any point of time. You have a flexibility. You can study on the device of your choice. You always carry your phone with yourself so you can access the classes from anywhere. We have a question bank which consists of 25,000 plus question. High yield question are there, clinical based question and with explanation. So this is going to be very beneficial for all of you. We are having this iconic subscription also where you get access of India's two best platform, that is Unacademy and the Prep Ladder. So you are going to get all the plus benefit of Unacademy. Like I said, live classes, recorded classes, question bank, live tests, live quizzes and the PDF. Along with that, you get access for the Prep Ladder. In this, you can access the clinical and integrated essential of Prep Ladder, video lecture from the Dream Team, Question Bank 3.0 with active guidance, rapid revision and snapshot, and you will also be provided with the Treasure and Dream Note. Good morning, Dr. Soumya. So we are having this special class also on the Unacademy app. This is also free of cost, but they are way more special from YouTube session because they are always and always live interactive sessions are there. Polls features are there by which class is very engaging. Raise hand feature is also there by which you can talk to educator in the live session. If you follow an educator, you will get notification of their upcoming classes, and after the lecture you can download the PDF and revise it anytime, anywhere. We are having this Unacademy Lite for NEET PG also. In this, you can access all the test series that is related to our NEET PG category. In this, we have subject-wise test series also, system-wise test series, full-length mock test paper, previous year question paper, test series curated by top educator. And the grand test for the NEET PG, INSCT, and FMG will be also there. So if you are looking for only the test series, you can go for this Unacademy Lite. This is the free test calendar for the upcoming week. So do take the screenshot and do give each and every test because tests are very important to analyze your preparation. So we are started with this batch on UPSC CMS revision and the previous year question batch that is started on 23rd May. We are also starting this batch that is target next 2023 batch. Subject wise batch will be there. 6-month duration, total duration will be there, and that is started on 25th May. So moving further, we are having this NEET PG previous year question bank also where you get access of a 4-year paper of NEET PG, INSCT and FMG, and that is going to help you to quick revise before the examination, and 180 plus question is also available for the free users. So moving further, auto daily practice paper is also started. After the every plus classes you take, you will get 5 to 10 MCQ that is hand-picked by your educator, and that is related to topic you studied in that session, and that is going to enhance your conceptual understanding. We are launching this UPSC CMS, so 1 month fee is 2,475, 2-month fee is 4,500 only. So we are going we are started with this first prof batch also. 3-month prices 4,950, 6-month prices 9,000, 12-month fee is 10,800 only. So this is the fee structure for the NEET PG Plus subscription. This is the fee structure for NEET PG Iconic subscription. This is the fee structure for NEET PG Lite subscription, and this is the fee structure for First Prof subscription. So as per your requirement, you can take your subscription and start your preparation right now. So moving further, we are going to continue this excretory system only. So first coming to the DCT, and then we will study about the collecting duct also. So first coming to this DCT. The distal convoluted tubule, this is responsible for sodium chloride reabsorption as well as calcium reabsorption. And for this reabsorption, the channel that is required out here is sodium chloride co-transporter. This sodium chloride co-transporter is basically present at the apical end of the DCT cell. Suppose this is our DCT cell. So this is the lumen part, and out here this is the blood vessel end. Okay, so this is the blood vessel, this is the DCT, and this is the lumen of our nephron. So this DCT consists of the sodium chloride co-transporter at the apical end, because this end is known as basolateral end that is near the blood vessel is known as basolateral end, while opposite end is known as apical end. So this end is apical end, and at the apical end we have this sodium chloride co-transporter, and by this co-transporter what happened, sodium and chloride is taken inside the DCT cell, not the calcium, it is the chloride. So sodium and chloride move from urine to the DCT cell via the sodium chloride co-transporter. Since it is a co-transporter, it is a classical example of a secondary active transport, and this co-transporter is blocked by this thiazide diuretics, and mutation of this sodium chloride co-transporter lead to this Gitelman syndrome. So do remember this point. It is important from the exam point of view. Sodium chloride co-transporter lead to this Gitelman syndrome. So moving further, next channel out here is the transient receptor potential vanilloid 5, TRPV5. It is also present at the apical end. So what it do? It transport the calcium from urine to the cell. And that's why this transient receptor potential vanilloid is regulated by this parathormone and vitamin D. What does these two hormones do? It increases the calcium reabsorption. How it is going to increase the calcium reabsorption? By activating this transient receptor potential vanilloid 5. Is this clear with everybody? So what happened? Due to presence of sodium chloride co-transporter, sodium and chloride uptake is there. And due to presence of this transient receptor potential vanilloid 5, calcium uptake is there. And now this calcium which is entered into the DCT cell, it has to go into the blood vessel. And so for that we have this sodium calcium exchange. This sodium calcium exchanger is present at the basolateral end of the DCT cell. So what does it do? It moves this calcium into the blood, and in exchange what happens? Sodium ion move from the blood vessel to the DCT cell. Is this clear? So see, you can see this diagram also. This is the transient receptor potential vanilloid 5, which is basically present at the apical end of the DCT cell. So this is the DCT cell, this is the apical end, because out here the lumen part is there. So from the lumen, this calcium is uptaken into the DCT cell via this transient receptor potential vanilloid 5. And this DCT cell, what does it do? It moves this calcium back into the blood vessel via this sodium calcium exchanger. So in exchange, what happens? Sodium ion move inside the DCT cell. That's how calcium is uptaken into the blood vessel via these two channels. Is this clear with everybody? Do reply fast. Is this clear? What is the role of DCT and how it is played by the various channels? Do reply fast. Shall we move to the further? Everybody, is this clear? Okay, moving further. Now coming to the JG apparatus, the most asked question comes from this topic, JG apparatus. This JG apparatus lies between a glomerulus and junction of a thick ascending limb of loop of Henle and the DCD. Junction of these two and the glomerulus lies when close to each other, it forms this JG apparatus. So suppose this is our nephron, this is our glomerulus, and this is our nephron. This is the descending limb of loop of Henle. This is proximal convoluted tubule. This is descending limb of loop of Henle. This is ascending limb of loop of Henle. And out here the DCD starts. Distal convoluted tubule starts. Okay? So this JG apparatus lies at the junction where the glomerulus meets to the junction of this ascending limb of loop of Henle and the DCD. So this is important. Do remember. Where this JG apparatus is located, it is lying between the glomerulus and the junction of a thick ascending limb of loop of Henle and the DCD. Now coming to the point, what all are the cells that is present in this JG apparatus? First and foremost important one is the JG cells. This JG cell are the modified cells of modified smooth muscle cell of afferent artery. So they are basically smooth muscle cell of afferent arteriole, but they are the modified form. Why they are modified form? Normally the smooth muscle undergo constriction and relaxation, but out here this JG cell consists of a renin enzyme. That renin is required for conversion of angiotensinogen into angiotensin 1. So this renin is stored in this JG cell in the form of granules. That's why this renin, since it is stored in the form of a granule, it is also known as a granular cell of a kidney. Okay, so first cell is the JG cell. They are the modified smooth muscle cell of our afferent arteriole. Next is the macula densa. This macula densa is not a part of a DCD. This is very important. Earlier it was said it is a part of a DCD, but now it is concluded that it is not a part of DCD. It is a part of a thick ascending limb of loop of Henle. Is this clear? Everybody? Do remember this one. This is important because earlier it was said that it is a part of DCD, but now it is concluded that it is not a part of DCD. It is a part of ascending limb of loop of Henle. Why it is a part of ascending limb of loop of Henle? Because this macula densa cell also consists of the sodium potassium twice chloride co-transporter. So this co-transporter is also known as Barton channel, remember? So this channel is a part of ascending limb of loop of Henle, and this is also present in our macula densa. So it is known as a part of thick ascending limb of loop of Henle, not a part of a DCT. Is this clear with everybody? Do reply fast. Is this clear? Next one, that is extraglomerular mesangial cell. They are present outside the glomeruli. So this is the extraglomerular mesangial cell. So since they are present outside the glomeruli, they are known as extraglomerular mesangial cell. They are also known as the Lasix cell. They are also known as supporting a cell of a kidney. Okay, now coming to the first one, that is the JG cells. So these JG cells are the seen in afferent arteriole, and they are basically modified form of smooth muscle cell of afferent arteriole. They stored the renin in the form of a granule, so that's why it is known as the granular cell of a kidney. The most important part, what all are the stimulus that is going to cause release of this renin from the JG cell? So the most important one is the hyponatremia, hypotension, and the sympathetic nervous system activation is going to activate the granular cell to release the more and more amount of renin. Now, what does this renin do? It converts this angiotensinogen into angiotensin 1. This angiotensin 1 is converted into angiotensin 2 in the presence of ACE enzyme that is coming from our lungs. So what does this angiotensin do? We all know in the RAS system we already studied. This angiotensin 2 is going to cause a vasoconstriction. So due to this vasoconstriction, blood pressure is going to increase. And this also stimulates the adrenal gland to release more and more of aldosterone. So what happens? The sodium reabsorption is going to increase in this situation. So what is the overall effect of release of this renin? That blood pressure is going to increase. So the most common stimulus that is going to stimulate the renin production is our hypotension and the sympathetic nervous system activation. Is this clear, everybody? So hypotension and the hyponatremia is also going to cause stimulation of this RAS system. So whenever there is an overactivity of this RAS system, what happens? Blood pressure is going to increase. So it is going to cause this hypertension. Okay, so the most important point is how this renin is released. What all are the stimulus? Hyponatremia, hypotension, and sympathetic nervous system stimulation is going to release this renin from our granular cell of kidney. Okay, is this clear with everybody? Now, coming to the clinical aspect, the direct renin blocker is our L-screening. So what does it do? It is going to block the renin release, so blood pressure is not going to increase. So that's why it is used in the treatment of hypotension. So do remember this L-screening is a renin blocker. So that's why it is used in the treatment of hypertension. Now coming to the next cell, this is the macula densa. It is a part of the ascending limb of loop of Henle, not the DCD. What does this macula densa do? This macula densa act like a GFR sensor. They are sensitive to sodium and chloride ions. And most importantly, it is more stimulated by the increase of this chloride ion as compared to the sodium ion. So what happens when GFR increases, the amount of sodium chloride that is filtered from the glomerulus will increase. So this is going to activate our macula densa. Okay. So when macula densa is activated, what happens? Our adenosine is released. And what does this adenosine do? This macula densa is going to release this adenosine. This adenosine diffuses from there. It goes to our JG apparatus location. So this is our, suppose this is our glomerular. This is our lumen of a thick ascending limb of loop of Henle. This consists of this cuboidal macula densa. So macula densa is going to release this adenosine. So this adenosine goes to our afferent arteriole. This is our afferent arteriole. It goes to this afferent arteriole. It causes calcium influx into this afferent arteriole. So due to this calcium influx, what happened? A smooth muscle will undergo constriction. So overall, what happened? The GFR is going to decrease. So that's how our macula densa is auto-regulating our GFR. This is auto-regulation of GFR done by this macula densa. And this is known as Anybody? This is known as, we already discussed in the first session, this auto regulation of a GFR is known as, anyone? Tubuloglomerular feedback. So what happened? Due to increase in GFR, the GFR is going to decrease. So this is a classical example of a negative feedback mechanism. Okay, is this clear with everybody? Jaldi reply kijiye, is this clear? What is the role of our JG cell? What is the role of this macula densa? If anybody has any doubt, you can ask in the session. Okay, fine. Moving further. So it is a classical example of negative feedback mechanism. It is also known as tubuloglomerular feedback. And now last, the third cell of our JG apparatus is known as extraglomerular mesangial cell. They are also known as the Lasik cell, Wilkinson cells, and pseudomesenarian cell. So they are known as supporting cell of kidney, and they are also important in immune complex function. So do remember this point. The extraglomerular mesangial cell is also important for immune complex formation. Next, coming to the erythropoietin. Why we are studying about this erythropoietin out here? Because majority of erythropoietin, about 85% of erythropoietin is secreted from our kidney. From which cell of kidney? Do remember. It is secreted from interstitial cell in the peritubular capillary bed. So this point is very, very important to remember, everybody. So, rest 15% of erythropoietin is produced from liver, spleen, salivary gland, brain, and the uterus. And what is the stimulus that causes production of this erythropoietin? The hypoxia. So, whenever the hypoxia is there, whenever the partial pressure of oxygen decreases in our body, the requirement of oxygen is there. So, to increase the oxygen transport, RBC production is required. And that's why erythropoietin is released by this hypoxia. And now coming, this erythropoietin receptor are present on the committed cell of a bone marrow. This is important. Where this erythropoietin receptor are present, they are present at the committed cell in the bone marrow. So they are going to stimulate that cell. So the production of committed cell increases, and that's how RBC production is there. And that's how our hypoxia will be combated. So that's why erythropoietin is important out there. Okay, 85% is released from interstitial cell in the peritubular capillary bed. So do remember this point. So moving further to the next part of our nephron, that is the collecting duct. So this collecting duct is basically the site of all hormonal action, like our aldosterone, like our vasopressin antidiuretic hormone act at the level of our collecting duct. So this collecting duct basically consists of a two-part cortical collecting duct and the medullary collecting duct. So this cortical collecting duct consists of two cells, the principal cell and the intercalated cell, that is P cell and the I cell. So, okay. Now coming to the detail of each one. First coming to this aldosterone. This aldosterone is our mineralocorticoid, and they act at both principal cell as well as intercalated cell. Now coming to the function of this aldosterone. What is the function of this aldosterone? It causes reabsorption of sodium in water, and it causes excretion of potassium and hydrogen ion. Now coming to the point, the reabsorption of sodium, water, and excretion of potassium and hydrogen occur at which level? It occur at the level of P cell or the I cell. So now coming to the important point, let me write out here. The reabsorption of sodium, reabsorption of a sodium and water, and excretion of potassium ion, this too occur at the level of a P cell. Next, that is excretion of hydrogen ion is done at the level of I cell. Is this clear with everybody? So do remember this point. So coming to the major stimulus for aldosterone release is the hyperkalemia, because it is going to excrete this potassium ion. So since it is involved in the major electrolyte balance, it is also known as a life-saving hormone. Now coming to the action, how this aldosterone act by to cause this sodium water reabsorption or hydrogen ion excretion or potassium ion excretion. First, coming to this channel that is important for the action of aldosterone is epithelial sodium channel. This epithelial sodium channel is basically present at the apical end of the P cell. So suppose this is our P cell of our collecting duct. So this is the lumen part of our nephron, and this is the blood vessel end. So what happened? This epithelial sodium channel is present at the apical end. This is our P cell of our collecting duct. This is the blood vessel. This is the lumen part. So this end is known as apical end. So this epithelial sodium channel is basically present at the apical end. And what does it do? It causes the transport of the sodium ion inside the P cell. And we all know the sodium ion is the most osmotically active substance. So it is going to bring this water molecule also inside this P cell. Okay? Is this clear? Everybody? So this transport of water from urine to the P cell is done by this passive absorption via the sodium reabsorption. Okay. So this epithelial sodium channel is blocked by diuretic drug or amiloride. So what happened? Whenever there is an overactivity of this epithelial sodium channel, there will be enhanced reabsorption of sodium and water. And when there is enhanced reabsorption of sodium and water, blood pressure is going to increase, and this leads to a syndrome which is known as Liddle syndrome. So do remember, overactivity of epithelial sodium channel is going to cause this Liddle syndrome. Okay, is this clear? So the next important channel is the renal outer medullary potassium channel, or our ROMK channel. This is also present at apical end. And what does it do? It transports the potassium from cell to the urine, because aldosterone, what does it do? It causes potassium ion excretion. So that's why hyperkalemia was the major stimulus. So what does this ROMK do? It causes transport of this potassium from the P cell to the urine. Okay? Is this clear with everybody? So the two important channel out here is epithelial sodium channel and the ROMK channel. Is this clear? Everybody do reply fast. If anybody has any doubt, you can ask. Okay, moving to the diagram, this is our P cell. This is the lumen part of our nephron. This is our blood vessel. From blood vessel, the aldosterone will move to this P cell. In P cell, it is going to bind with the mineralocorticoid receptor. This mineralocorticoid receptor is basically present in anybody? This mineralocorticoid receptor is present in our cytoplasm. What happened? This hormone receptor complex will be formed. This hormone receptor complex eventually goes to the nucleus of a P cell for its action. So do remember this point. Any cytoplasmic hormone will eventually go to the nucleus for its action. And what does it do? At the level of nucleus, it is going to upregulate these two channels, that is epithelial sodium channel and the ROMK channel will be upregulated. So there will be enhanced reabsorption of sodium and water, and there will be enhanced excretion of this potassium ion. So that's our aldosterone. Is this clear with everyone? So see the same diagram, I guess. Aldosterone enter the P cell from the basolateral end. It is going to bind with the cytoplasmic receptor. So the eventually the complex is going to go to the nucleus and it upregulate this epithelial sodium channel and the ROMK channel. So there will be enhanced reabsorption of sodium and water, and there will be enhanced excretion of this potassium ion. Okay, so this is the same diagram. So skipping this one. So the the mineralocorticoid receptor blockers are spironolactone and the potassium sparing diuretics. After the aldosterone, and now moving to our antidiuretic hormone, our vasopressin. What is the action of this vasopressin? We all know it is exclusively concerned with the water reabsorption. And for water reabsorption, it acts at the level of P cell of cortical collecting duct as well as medullary part of a collecting duct. Now, important question is there. What all are the receptor that is required for the action of a vasopressin? So, receptor, the first receptor is the aquaporin 2. What happened? The aquaporin 2 is basically present at the apical end, and this is the ADH dependent. And what does it do? It transport the water from urine to the P cell. So, suppose this is our P cell. This is the blood vessel end and this is the lumen part. So out here the aquaporin channel is there. This is our aquaporin. So this aquaporin 2 is basically present at the apical end and it is AGH dependent. It causes transport of water from urine to the P cell. Next channel that is required for this water uptake is G protein coupled receptor V2. So this G protein coupled receptor V2 is basically present at the basolateral end. Okay, so this is present at the basolateral end. So we are having this V2 blockers. What does this V2 blocker do? It causes selective water excretion because the water reabsorption will not be there. So that's why this V2 blockers are also known as aquaretics. In this we have conivaptons and our tolvaptons. So this clinical part is also important to remember. So moving to the diagram, how the water reabsorption is going to occur. So see what happened. Let me draw this one for all of you. Suppose this is our P cell. And this is our blood vessel. This is our flowing urine from the lumen of nephron. So here we have a lumen. This is our P cell. And this is our blood vessel. So the end that is near the blood vessel is known as basolateral end, and opposite end is known as apical end. So at apical end we have this aquaporin channel. And at the basolateral end we have this G protein coupled receptor V2. So what happened? The ADH will be coming from the blood vessel. It will bind with this extracellular receptor. We all know G protein coupled receptor. It is an extracellular receptor and our ADH bind with the extracellular receptor G protein coupled receptor. So what happened? Due to this binding of this G protein coupled receptor with this ADH, our secondary messenger will be released inside the cell. And which secondary messenger will be increased inside the cell? The cyclic AMP will be increased inside the cell. And this cyclic AMP, what does do? It causes phosphorylation of protein, activation of protein kinase is there, and that's how the aquaporin channel is formed. And due to the formation of aquaporin, what happened? Water reabsorption from urine to the P cell occurs. That's how our ADH work. Is this clear with everybody? To reply fast, is this clear? Okay, fine. Moving further. Same diagram is there. This ADH bind with this G protein coupled receptor V2. So adenylate cyclase enzyme will be activated. Cyclic AMP will be released inside the cell. So it is going to activate the protein kinase. So it is going to cause a phosphorylation of transcription factor, and the aquaporin channel is formed. Coming to the next. This is a summary part. Do remember this one. This is important. Two type of water reabsorption we studied. Facultative water reabsorption and obligatory water reabsorption. This obligatory water reabsorption occur at the level of PCT. 70% of water is reabsorbed from the PCT irrespective of body osmolarity. So it is not any hormonal control. So it is not under this ADH control. And the process by which the water is reabsorbed in the PCT is our osmosis. Okay. Next is the facultative water reabsorption that is occurring via this aquaporin 2, and this is our ADH dependent, and that depend upon body osmolarity. If osmolarity increase, there will be more water reabsorption, more facultative water reabsorption. When osmolarity decrease, the facultative water reabsorption also decreases. Is this clear? So two type of water reabsorption is there, facultative water reabsorption as well as obligatory water reabsorption is there. Okay. So moving further, we are having three type of vasopressin receptor, V1, V2 and the V3. First coming to this V1 receptor. This V1 receptor is basically present at the vascular smooth muscle, and since when this V1 receptor is activated, it is going to cause this vasoconstriction. Now coming to the clinical part, the V1 agonist like telepressin, it is also going to activate the V1 receptor, so it is also going to cause a vasoconstriction. So that's why it is used in the esophageal varices, because in esophageal varices, when vasoconstriction occur, blood loss will be prevented, or you can say blood loss decreases. So this is the important point to remember. Next receptor, the V2 receptor. The V2 receptor is present at the two level. First at the level of collecting duct, and when it is activated, it is going to cause this water reabsorption. It is also present in vascular endothelium, and when it is activated in vascular endothelium, it is going to activate the formation of von Willebrand factor. So now coming to the clinical aspect related to this one, when we give this desmopressin intranasally, it is going to activate the V2 receptor and von Willebrand factor is released. So that's why we give this desmopressin in a von Willebrand disease. Is this clear with everybody? Do reply fast. Is this clear? Next is this V3 receptor. This V3 receptor is basically present in the anterior pituitary, and when it is stimulated, it is going to release this adrenocorticotrophic hormone. So we have three V1 receptor, V2 receptor and the V3 receptor. Okay, so now coming to the next one, next topic, that is the free water clearance. This free water clearance can be either positive, negative or zero. What do you mean by the free water clearance positive? Means more water is present in a urine as compared to normal situation. So we can say out here the diluted urine will be there. And this situation is classically seen in diabetes insipidus where ADH is absent. So since ADH is absent, water is not reabsorbed from the aquaporin. So the diluted urine will be there, and in this situation, the free water clearance will be positive. Okay, next one is the free water clearance negative. What do you mean by this free water clearance negative? Means urine is having less water as compared to normal situation. So in this situation, the concentrated urine will be there. Okay, and this concentrated urine is classically seen in syndrome of inappropriate ADH. What is the syndrome of inappropriate ADH? Anybody? What is the syndrome of inappropriate ADH? Do reply fast. Anybody? So see, what is syndrome of inappropriate ADH? During a stressful situation, during surgery, what happened? The ADH production increases. Beside any osmolarity of our plasma, irrespective of osmolarity of plasma, in this situation, ADH increases. So what ADH do? It is going to cause more water reabsorption. So in this situation, what happened? The urine will become more concentrated. So this is our syndrome of inappropriate ADH. Is this clear? So moving further, same thing is written out here. Plasma osmolarity is normal, but still ADH is secreted. So what ADH do? It is going to cause a more water reabsorption. So plasma will become hypotonic. Plasma volume is going to increase, and the urine will, in this situation, will become concentrated. So we can say the free water clearance is negative in the syndrome of inappropriate ADH. Is this clear? And the last situation, the free water clearance can be either zero. What do you mean by this free water clearance? Zero means kidney has lost its ability to concentrate or dilute the urine. Okay. So now coming to the next hormone, that is the natriuretic peptide. First was aldosterone, second was our vasopressin. Now coming to the natriuretic peptide, it also act basically at the level of a collecting duct. So we are having three type of natriuretic peptide, that is atrial natriuretic peptide, atrial natriuretic peptide, which is isolated from atria, that's why it is known as atrial natriuretic peptide. Next is the brain natriuretic peptide, it is isolated from brain, that's why it is known as the brain natriuretic peptide or BNP. It is also isolated from cardiac ventricle. Next is the C-type natriuretic peptide, which is isolated from vascular endothelium. Okay. So now moving further, what is the function of this natriuretic peptide? The first and important function is the natriuresis. It causes sodium excretion. And we studied in our GFR, it acts as a relaxing agent for the mesangial cell. And when mesangial cell is relaxed, there will be the opening of glomerulus and the filtration coefficient is going to increase and it is going to increase the GFR. So there is two function of this natriuretic peptide, that is in natriuresis, and our atrial natriuretic peptide act as a relaxing agent from the mesangial cell. Okay. Next, the physiological antagonism is present in our kidney. What is this physiological antagonism? Our RAS system is going to release the aldosterone from a kidney. So what does this aldosterone do? It causes sodium retention. Is this clear? Our natriuretic peptide causes natriuresis. So this physiological antagonism is present in our kidney. Is this clear? Everybody? Okay, moving further. What happened? What does this aldosterone do? It causes sodium reabsorption. So since sodium is reabsorbed, blood pressure is going to increase. So it is going to cause a pressure diuresis. And due to pressure diuresis, what happened? And sodium and water excretion will increase. Okay, when sodium reabsorption is there, sodium is going to increase and that is going to stimulate our atrium to release A-type natriuretic peptide and that causes natriuresis. Okay, so what we all are seeing, the action of aldosterone is increase in sodium reabsorption, but overall action is in our sodium level is decreased, sodium excretion is there. So we can say aldosterone is present in our body, but the action of aldosterone, that is sodium retention, is not seen. So this phenomena is known as aldosterone escape. Means aldosterone is present out there, but this action is not seen. So it is known as aldosterone escape. So this aldosterone escape is due to first pressure diuresis and second is the atrial natriuretic peptide. Is this clear? So this terminology is important. Do you remember everybody? Is this clear with everybody? Do reply fast. Is this clear with everybody? Do reply fast. Okay, fine. Moving further. Same thing is written out here. Aldosterone action is escaped by the kidney even if it is present. So it is known as aldosterone escape, and it is due to atrial natriuretic peptide and the pressure diathesis. So moving further. Okay, we are done with this collecting duct also. Is this clear? अभी तक सेशन में किसी को कोई डाउट है तो क्लियर कर सकते हैं. Further we will move to the question part related to today's session. To reply fast, is this clear with everybody? All the concept regarding the DCT and the collecting duct. Is this clear? Am I audible to all of you? Or all of you are facing the voice not clear? I think Dr. Varun, you have to refresh yourself and rejoin. Everybody, is this clear? All the concept regarding the DCT and collecting duct? So we are moving to the question part. First question of our today's session. What happened in the vasopressin escape on a syndrome of inappropriate ADH? Decrease area secretion, increase osmolality of urine, upper regulation of aquaporin 2 receptor, down regulation of aquaporin 2 receptor. So everybody answer this question fast. This is a nice question. We studied about this aldosterone escape. The question is asking about vasopressin escape. So everybody answer this question. What happened in a case of a vasopressin escape on a syndrome of inappropriate ADH? Everybody answer this question fast. What do you mean by this vasopressin escape? Means vasopressin is present, but its action is not seen. What is its action? Water reabsorption is not occurring. Okay, since water is not reabsorbed, water will be excreted out of urine. So osmolality of urine is going to reply fast. Osmolality of urine will decrease and not increase. Okay, when aquaporin 2 receptor are upregulated, the action will be increased. So the vasopressin action will not be escape in this situation. Okay, so what do you mean by this vasopressin escape? Vasopressin action is not seen. And when does it occur? When the receptor are not working. Down regulation of receptor is there. Internalization, destruction of receptor is there. Then the vasopressin action will not be seen. And we can say vasopressin escape is there. So answer is D. Is this clear with everybody? Do reply fast. Is this clear? Shall we move to the further? Coming to the next question. Erythropoietin is or are produced by JG cell, interstitial cell of peritubular capillary bed of kidney, pars recta of PCD, macula densa, or the mesangial cell. Erythropoietin is or are produced by No, it is not produced from GG cell. It is produced by interstitial cell of a peritubular capillary bed. GG cell produce our enzyme that is known as renin. Okay, coming to the next one. Renin is secreted by GG cell, macular densa, mesangial cell, or the glomerulus. Renin is secreted by. Yeah, way true. It is secreted by GG cell. Angiotensinogen is secreted by kidney, lung, liver, or brain. Angiotensinogen is secreted by. It is secreted by the liver. Do you remember? Very good, Dr. Diana. Coming to the next one. Conversion of this angiotensin 1 into angiotensin 2 occurs in kidney, lung, liver, or RBC. Conversion of angiotensin 1 to angiotensin 2 occurs in. Yeah, wait. Answer is lung. Coming to the next one. The angiotensin 2 causes all of the following except stimulation of those aldosterone secretion, increase ADH secretion, vasodilation. Everybody answer this question fast. Angiotensin 2 causes all of the following except. No, it causes stimulation of our center. Aldosterone secretion is there. It stimulates our kidney to release this mineralocorticoid. ADH secretion also increases, but it causes a vasoconstriction and not a vasodilation. So answer is D. Very good, Dr. Dayanand. Coming to the next one, which is the most important in our sodium water retention. Our RAS system, atrial natriuretic peptide, brain natriuretic peptide, or the vasopressin. Which of the following is the most important in sodium water retention? No. Vasopressin is responsible for water reabsorption only. It is not regulating our sodium retention. But this RAS system is going to cause release of this aldosterone. Aldosterone is going to cause sodium and water retention both. So it is the most important in sodium water retention. Is this clear with everybody? Answer is not D. It is A. Very true, Dr. Sumit. Coming to the next one. Macular densa is present in collecting tubule, proximal convoluted tubule, distal convoluted tubule, or the loop of Henle. Good morning, Dr. Ashwin. Macular densa is present in yes, Dr. Rana, it's loop of Henle, not the PCT, not the DCT. Earlier, it was said that it is a part of DCT, but now it is concluded it is a part of a thick ascending limb of loop of Henle. No, no, it is not a part of proximal convoluted. It is not a part of PCT. Earlier, it was told that it is a part of DCT, but now it is concluded it is a part of a thick ascending limb of loop of Henle, because this macular densa also consists of the sodium potassium twice chloride co-transporter, which is also known as the Barton's channel, and this is classically present in a ascending limb of loop of Henle, not in the DCT. So answer is D. Is this clear with everybody? So do remember this point. This is very, very, very important. Okay. Coming to the next one. What causes a raised angiotensin in the blood? Increase the blood volume, raise the cardiac output, decrease the blood pressure, increase the sympathetic tone. So everybody answer this question. Okay, sorry. This question. What causes a raised angiotensin in the blood? Yeah, very true. Decreased blood pressure is going to activate our RAS system. Increased sympathetic tone is also going to activate our RAS system. So answer is both the C and D. Is this clear? Everybody, is this clear? So answer is both the C and D. Coming to the next, okay, we done this one. Erythropoietin is secreted from interstitial cell. Coming to the next one. Erythropoietin is inhibited by estrogen, progesterone, thyroxine, or the testosterone. Erythropoietin is inhibited by to reply fast, everybody. The erythropoietin is inhibited by This erythropoietin is inhibited by estrogen. That's why RBC count in female is still less. Okay, so answer is A. Is this clear with everybody? Coming to the next one. Atrial natriuretic peptide act at which site? Glomerulus, loop of Henle, PCT, or the collecting duct? Atrial natriuretic peptide act at the level of collecting duct for the natriuresis. It act at the level of a glomerulus also to increase the GFR or decrease the GFR. So answer is both A and D. There is two function of our atrial natriuretic peptide, that is R. It causes a relaxing agent for mesangial cells, so it is going to increase the GFR. It causes natriuresis by acting at the level of collecting duct. So answer is both A and D. Is this clear? Okay, coming to the next one. Aldosterone mainly act upon PCT, loop of Henle, glomerulus, or the collecting duct. Yeah, way through it act at the level of a collecting duct. Coming to the next one, action of ADH is reabsorption of sodium in the DCD, reabsorption of water in DCD, reabsorption of a glucose in the DCD, reabsorption of a bicarbonate in DCD. What is the action of this ADH? Everybody answer. Option A is the reabsorption of sodium in DCD, not the PCD. The ADH causes what? Sodium reabsorption. There is no action of ADH which causes this reabsorption of sodium. ADH is only and only responsible for water reabsorption. Yeah, answer is B only. It is only responsible for water reabsorption. B only. Is this clear, everybody? Okay, coming to the next one. Where does ADH don't act? PCT, collecting duct, collecting tubule, or the DCT? Where does ADH don't act? Everybody answer this question fast. Yeah, very true, very true. It don't act at the level of a PCT because PCT absorption, water reabsorption in PCT is 70%. It is obligatory water reabsorption and it is not under any hormonal control. Answer is A. Very true. Come. Okay, that was the last question of today's session. So if anybody has any doubt regarding today's session, you can ask. You can clear out any doubt related to today's topic. So how was the session? Do you all like the session? Most welcome, Dr. Dayanand. Okay, fine. That's all for today's session. If you like the session, do share and like the session. That is important because जितना ज़्यादा share करोगे class next time से उतनी interactive होगी. So do share everybody. Thank you so much for joining. See you all in the next session. Do subscribe our channel. That is Unacademy Live NEET PG. And press the bell icon so that you will get notification of any upcoming classes. So do subscribe our channel and press the bell icon. So let's crack it together. Do more and more MCQ. That is the only key for the success. So do more and more MCQ. You will definitely able to achieve your target. You will definitely crack your exam with good rank. So let's crack it together. Most welcome everybody. Okay, this is the referral code. If anybody wants to join any paid course, you can use this referral code to get additional 10% off. Most welcome everybody. So you can follow me on Unacademy page also. My page on Unacademy is unacademy.com/KGMC. You will get the link of this page in the description box. Also, you can follow me out there so that you can join many more classes out there also. So follow me out there. That's all. Thank you so much for joining. See you all in the next session. Bye-bye, everyone.